It's very easy working with the medical team here at Rush to facilitate these patients home. The case managers, the doctors, the medical rounds, we discuss these patients. Every patient is different and all their needs at home are different. So understanding an individual patient and their family support and needs in the community, we base that assessment in helping to find the best possible plan for these patients. Some patients who live at home may not be safe to go home right away. Some patients who live with family but they're never home may not be safe to go home. So assessing with the medical teams and working with their team approach and their transitional care model helps these patients get home safely and be treated at home and to stay home.
You know, still not everybody understands what home health care is, so there's still a lot of education that needs to go on about what home health care can do, how, what services we can provide. Some people have the antiquated view of your home health, you go in there, take the blood pressure, and you leave. And I think those days of home health care, I think it probably does occur, but that's not the focus anymore. Now it's really going in disease state management, education. If we need to start IV, we'll do the infusion in the home. Wound vac, wound care. That's why the acuity of these patients for home health has increased quite a bit. So I think educating the healthcare field itself about what home health care is, and then again to the patients as well. And I think every day, every time I come down, I also notice how much progress they made also in the communication, and then also the numerous amount of patients they're talking about. And those things are really rewarding. And say, okay, we did this for this patient. We got this involved. Whether it be in transportation or trying to get, I think 2 or 3 of the patients they were getting palliative care involved and those type of things. So, getting those different resources involved to help the patients, that is rewarding. It's we are making a difference. We are helping the patients, we're helping the community. So that is definitely rewarding. The Bridge program is about communication, and what it's doing is establishing a process to communicate. And from there, it's establishing a process to communicate that allows us to get reportable data, objective reportable data. We always feel if you don't measure something, how do you know if you're improving or not improving? So for this model, there's the biggest one is always, which a lot of people look at, is readmissions. Are we reducing the number of readmissions back to the hospital? And so that is a large measurement. Medicare has another score sheet, basically it's called OASIS. When the nurses go in and they do a start of care, or sometimes people say open up the patient. They go through and they have to fill out what's called an OASIS, and that scores the patient basically on the severity of how sick the patient is, and then they do the same thing when they discharge the patient. And we see, did that patient improve? Did they get better with the mobility? Did they get better with the medications? Did they decrease their pain?
So it is an evidence-based transitions of care model. It utilizes social workers in the care coordination role, and focuses very much on not just the medical factors that we know impact patient outcomes after discharge, but equally important, it focuses on the psychosocial and environmental factors as being equally important to the patient's situation after they return home. So it's a telephonic intervention that basically involves a pre-assessment prior to discharge, typically done by an extensive review of the electronic medical record. Sometimes it might be participation in some interdisciplinary rounds or conversation with the discharge planners or case managers, as they're called here, or it could be the PCP's office, to learn or understand better what the discharge plan is. But a lot of times it is making recommendations to the inpatient team about things that we know are important in the post-discharge situation.
Hi, this is Stephanie. I'm a social worker with Rush Health and Aging, and I am just calling to see how things are going for you now that you're back at home. Okay. And are you having any problems with that? Okay. So have they been out to see you? Great, okay.
So that bridge program, I think, has really honestly helped us change home health in a very, very good way. So when we're looking at readmissions and we're looking at what's going on with a patient, it's not necessarily that a physician doesn't know how to treat them from a clinical standpoint. And I think clinical is a broad term in our language nowadays. So psychosocial and socioeconomic, what does that mean? What could that focus on? When a patient doesn't have the proper care for depression, for mental status changes, for transportation to the hospital to follow up with their physician, for looking at their medications, how are they going to get them? Why are they not taking them? How are their caregiver support at home? What's going on with that? So timing is definitely the key. We always say that if you don't get in front of a patient prior to discharge, discharge usually starts at admission, you're going to be behind. Well, imagine a patient going without proper medications for 48 hours. You're 24 hours too late. You need to get into that patient within 24 hours, and that was a standard that was set place by the Bridge team. When we came together as a home health team and the Bridge team together, we developed a perfect form. And what that perfect form did was that became our communication and collaboration tool. So what do we go to make sure that the patient's seen within 24 hours, the plan of care is discussed, and all the items below that they all fall into place.
Basically, there's just so many people behind the scenes that you don't know about. I've never knew there were any sort of people that worked in a Bridge team that helped identify high hospitalization rates and working with people really in the community. I always just thought that it was agencies that do that, never really realizing in the hospital there's so many people that are looking out for people's well-being, and it's really been a refreshing experience for me. We follow them up for 30 days. So on a weekly basis, I check in with the nurses to see how they're doing at home, if there's anything we can help with, if there's anything the social workers from the Bridge program can do to help them in the community, whether that be transportation needs, doctor's appointments, getting them into the clinic, whatever they're going to need to be successful at home. So we follow them for a period of 30 days, unless they are readmitted to the hospital. We meet weekly on a weekly basis on Tuesdays with Madeline to go over, and you guys kind of got a little bit of clips of us discussing those patients in detail, what their needs are, what's going on, any risks for readmissions, things to that nature. So we meet on a weekly basis to discuss those as well.
This program is very valuable. It's very valuable in that patients do not have to readmit through emergency room. They have that communication. When you have your auntie or your grandma who is short of breath and who has a nebulizer and you keep treating with the albuterol and there's not a change in symptom, having that nurse that you can communicate to who understands that there is a history of heart failure and it's perhaps an overloaded patient who can talk to the doctor in the medical terms. We forget that patients can't talk doctor language. Patients talk basic language, and having somebody who can translate that for them is a large, large thing.
So we are providing home health care services for patients coming out of the University of Chicago like we are here at Rush University Medical Center. We have a couple different projects going on over at University of Chicago which are slightly different from Rush. One is called the Mobile Integration Healthcare Practice. And this was started by physician Dr. Beck. So basically it was the first one in the state of Illinois about mobilizing healthcare. And what it does is takes the EMS services along with case management and at this point the cardiology group at University of Chicago. Now typically, when someone calls 911, the ambulance goes, picks up the patient, drops them off at the ER and gets them treated. So this is actually a way to start integrating the EMS services and home health care and the hospital team. So now what the idea was when the patient is discharged from the hospital, this kind of goes back to the communication model, the patient is discharged from the hospital, EMS would actually pick up the patient from the hospital, drive them to the home, and give a full report back to the home health care services. But with that said, is everybody's teaching the patient the same information along the whole way. So when the patient's in the hospital bed, they start, if it's a heart failure patient, teaching the patient about heart failure, teaching about their medications. And that teaching starts at bedside in the hospital. And then the EMS services will do the same thing. They'll actually pick up our telemonitor that goes in the home, sets that telemonitor up in the patient's home, get the first vitals, and starts doing some basic teaching there. Then they call home health services and our nurse, clinician who's going in the next day and saying, you know what, by the way, the doorbell doesn't work. You're going to have to knock on the door. Oh, guess what? The patient didn't go to their home. They went to the sister's house. At the last minute, they decided to go there. Or the patient only has 2 days of medical medications. We have to make sure they get some medications and they're timely. So our clinician is not, shocked or can't ring the doorbell, so they have a full understanding of what's going on with the patient when they get into the patient's home. And that's kind of going about bringing back the integration of communication. Our nurse then opens and also then reports fully back to the cardiology team at U of C, and they do also a weekly case conference with the cardiology team at U of C regarding those patients. So that was what we call the mobile integration healthcare practice. And then the second one is with their emergency room. So obviously one way to prevent readmissions is never have that patient admitted in the first place. So what they're doing now is saying that they're trying to establish in the ER, the emergency room, whether that patient needs home health care services up front. And if they do, they're actually paging our liaison to come down, meet with the patient, and say, can we start services now instead of admitting this patient? Obviously, the patient needs to be admitted, then they'll admit them. But they can triage the patient and say, okay, we do not need to admit this patient. But this patient does need home health care services because they are presenting themselves quite a few times in the ER, but do not need to be admitted. And then we can get home health care involved right away. And then from there, we'll follow up and make sure the patient goes to see their PCP, hopefully within the first 14 days. And we continue up with the home health care services.